Hello, everyone. My name is Neeraj Mistry. I'm the Chief Medical Officer at the Fatty Liver Foundation, and welcome to the third in our series called Live for Liver Health, and that's Learn, Inspire, and Value. This series is delivered with the kind support from Madrigal Pharmaceuticals, who gave the Fatty Liver Foundation a grant for this patient education and awareness series. Just a point of housekeeping before we dive into the webinar. Next slide, please. Any information relayed during this webinar is for education purposes. They are not prescriptions or management for your course of treatment. Please consult with your primary care provider, your specialist, and your care team, and take this information to them. But this is all for your education only. Next slide, please. So we go to my main slide I always use, that this is a complex disease that is related to so many aspects in that it is a confluence of many comorbidities, diabetes, high blood pressure, high cholesterol, obesity, overweight. And as a result of that, it converges on the liver, resulting in accumulation of fat, which can lead to fibrosis and cirrhosis and even to liver cancer. Huge costs implicated when it actually advances in pathology. And so prevention is always good, both on the impact on patient, but also on the impact on the health system. We haven't had any treatment for this for a long time, but we were delighted to have approval of Resdifra last year, and this is for the treatment, and we have many new candidates in the pipeline. But I think one of the main things I wanted to point out in this slide is that it's a psychosocial and medical disease in both etiology and response. And no matter how good our treatments are, we always have to also address those lifestyle factors. So it's not a single thing, but it's a combination of things. Next slide, please. So today, given the complexity of the issue related to steatotic liver disease, we have not the traditional type of expert that we usually have on these calls. We have Dr. Julie Sweetland, who's the Senior Advisor for Frameworks Institute. And Julie's going to tell us all about frameworks, but she's just really seasoned in this field on looking at how we frame issues for impact and to make a difference with them. So I'm not going to go through her bio. We'll share these slides with everyone, but Julie's experience will come out in the conversation that we have. Next slide, please. And just so we all on the same page, the briefing that I had given Julie in advance of this call, which most of you are familiar with, but I think just to summarize things, fatty liver disease, steatotic liver disease is a silent disease and often lives in the shadows of the comorbidities that we talked about. There hasn't been treatment for a long time, so it has been a reliance on lifestyle and diet. It's a very specialized disease, so it's not generally at the level of primary care or primary care providers. It's usually diagnosed at the specialist level. That's used to happen traditionally. There's deep stigma associated with fat and alcohol. And then we recently went through a nomenclature change from fatty liver disease to steatotic liver disease, NAFLD to MASLD, and NASH to MASH. Next slide, please. And this is the last slide, the second last slide in the recap, which is looking at now with the change in nomenclature, we have added alcohol to the broader, under the broader umbrella of steatotic liver disease. We have new therapeutics plus with the Ozempic revolution or GLP-1s. We have a burgeoning movement on patient advocacy and engagement. And then we also looking at peer support and care, particularly when it comes to lifestyle and behavior change. So that is our issue in a nutshell. Next slide. And this is more for people's reference. I always want to include the steatotic liver disease, so we see everything that falls under the umbrella. And the big block is with metabolic associated steatotic liver disease and increased alcohol intake with gradations of the extent of alcohol use. And then the other area of alcohol associated liver disease, ALD, and that's only with alcohol use. So those were the two categories that were added. Okay, next slide, please. So, Julie, we're delighted to have you. Thank you so much for joining us and our liver community. Um, so, before we dive into the framing, tell us about your journey, Julie, and what brought you to Frameworks Institute.
Great, thank you. And it's so good to be here with you at a moment when conversations about communication absolutely need to be had in community. What brought me to frameworks? That's a good one. It's been a while. I've been with frameworks for 13 years now. I'm a sociolinguist, and that means I study I study how small differences in language either reflect or create big differences in the world. And Frameworks is a group of social scientists. So I'm one linguist on staff. There are others, we have anthropologists, political scientists, sociologists, etc. And we study from our different academic backgrounds the culture and communications aspects of different social and scientific issues. So it's very much not we work in communications and in framing social issues, but it's definitely not the staffing of a typical comms shop, if you will. So the way I found frameworks is at the time I was working in education reform and on improving the way teachers are trained and prepared. And and as I was working on some policy documents, also some advocacy documents, and just having lots of conversations with people around education, making our education system better and fairer, I was finding myself really frustrated with the metaphors that people were using for teachers. Because I'm a linguist and I notice small differences in language. And so, if we're talking about teachers as being on the front lines, my mind goes, well, what does that mean? Does that mean the children are the enemy? Is this a war? Right? Or talking about how teachers are superheroes. And my mind goes, well, actually, it's not just one giant, one amazing skill that you have that you use to deploy to fight through, the world. Teaching is complex and you can learn it. And there are millions of us, right, as teachers. It's not a superhero, right? So that was just bugging me and sitting with me. But as a linguist, I was like, I am not the first person to think. Somebody has written a paper on metaphors in education. And so, I go into Google Scholar search and I start to look and I find the work of the Frameworks Institute and was just instantly captivated. And reading it helped me understand the research, right, that was available there helped me understand a lot of the conversations that I had been having around my passion issue, right, my advocacy issue, why I was encountering the same myths and misconceptions over and over again, why ideas that if you looked at the science or the evidence should not make any sense, why those were the ones getting elevated to the top of the list, why the simple easy fixes were being gravitated to, right, rather than the more complex, kind of comprehensive ways we should approach most social issues. So it helped me understand a lot of my frustrations as an advocate, but more importantly, once I started using the strategies that were recommended, I started having better conversations. I started having more breakthroughs in my advocacy work. So I put a Google alert on the organization just so I could see when new things showed up. And then one day my new job showed up in my inbox, Director of Learning, which involved adult education, which is what I was doing, sociolinguistics, right? Language for social change, language in culture, and social justice, which were the three things that job needed. And luckily, Frameworks agreed that was my job because if I had been stalking them all this time, surely it would have gotten awkward by now.
Wow, that is such an interesting journey. Tiff, we can take the slides down now and we can go into our fireside chat.
Mm.
Um, So, in public health, so at the level of patient care, the trend now is to talk about multidisciplinary teams,
Mm.
and that's while diverse, it's generally from the medical field.
Yeah.
When we deal with public health, we often, well, public health happens at a societal level, and that's the broader context. And we often talk about who's missing from the table
Mm.
when we have these conversations. And clearly, you've been someone who's been missing at the table. There's so much nuance and interpretation. And as you were talking, it just reminded me of one of my examples when I worked in infectious diseases, where as a doctor, I used to go tell people to wash their hands to prevent germ transmission. And lo and behold, only a few people used to wash their hands. And then we partnered with a priest who came in and said cleanliness is next to godliness. And lo and behold, everyone washed their hands, right? And so I was agnostic as to why they did it. I just needed a particular outcome that promoted health. And so understanding that social context with the nuance through communication, culture, etc., is so, so important. Um,
Could not agree more. We often say here at Frameworks that science needs social science, right? We can understand medically or from a public health point of view the epidemiology of something, the course of treatment, but those things have to happen with humans, right? In social contexts, in complex relationships. And that's where social science shines, right? Is understanding how humans work, right, together in different ways. So couldn't agree more.
Um, so, um, so if we had to sort of define framing, is it a tool? Is it an approach? Is it a lens? How do you talk about
Oh,
framing in that way?
yeah, well, wow, that's the most academic question I've been asked all day. Is it a framework, a tool, or a lens? I am not going to answer that question, though. I will say I'd like to think of framing, you know what, I think of it as a practice, but it could be those other things too. Framing is the process of making choices about how we present our ideas. And a frame effect is when a choice that we've made has a significant, predictable, and measurable effect on the outcome of that presentation, right? So those choices, there are lots of choices that we make, how to start, what to emphasize, how to explain it, when to zip the lip, right? All of these are framing choices that are a source of power for us as advocates, right? That if we can make those we are always framing, right? We are always making some sort of choice about how we're presenting the idea. And so we should always be doing that strategically. We should be thinking and reflecting and looking to evidence that if I put it this way, I get this outcome, and if I put it that way, I get that outcome. And what is it that I can control within that?
And so if we link framing to outcomes, then it becomes a more of a rational exercise. We have to think things through as opposed to framing things from a guttural or emotional perspective, right?
Yeah, I mean, I think that's like we are not our audience, right? And so I wouldn't want to, and it is important that people bring their authentic, personal, firsthand experience with issues, right? And so it's not that we shouldn't be ourselves or tell our stories. It's not just rational, but there are ways to tell a story, right? And there are ways to show up. And so I think at Frameworks, we think about it. What's the outcome you're trying to achieve? And then which set of framing practices can get you that? So an example, we worked with a group who wanted to ensure that more when teenagers go to for their annual checkup, um, that they would that there would be screening, brief intervention, and referral to treatment. SBIRT is what they called it. And the idea was that, a 13-year-old, 16-year-old, they go in for their annual checkup, and the doctor checks in with them on their tobacco, alcohol, marijuana, or other drug use, right? And the field of practitioners, this is a great, simple, easy to implement low cost, high yield intervention. And they talked about it as screening the adolescents, right, for substance use. As we looked to how people were reacting to that, if we put out the statement that adolescents should be screened for substance use at their annual wellness check, people were like, no, no way. Because they were envisioning basically a urine test, right? Which felt like a bit much for your back to school checkup, right? Why are you doing this to my kid? So when we tried, the doctor should ask adolescents about substance use at their annual wellness visit. Less of a strong reaction, but still no, because it sounded to people like an interrogation, a catch and punish, right? Kind of situation. Doctors should have a conversation with adolescents about substance use at every wellness visit. People were like, yes, yes, that should absolutely happen, right? And so what the goal there was, that's not the entire strategy, framing strategy for this issue. That's not the whole thing you need to do to implement this intervention, right, in the healthcare space. But getting that wording right was the difference between no way to let me hear more about that. Let me figure that out, right? And so if the goal is that intervention, you want to do that thinking ahead of time and do some exploration to know you are not your audience. How is your audience hearing it?
And so the word that's coming to my mind all the time now is complexity, right? Social
Yeah.
complexity, right? And the nuance of language. And I'm starting to be self-aware of how I use language and the words I use as well. So is there a process or to this practice? Is there a methodology that you use when you think about framing, when you consult to groups? Um,
Yeah, yeah, absolutely. And I will say developing that process has been kind of we're celebrating our 25th anniversary this year as an organization. Developing that process for the purpose of social change, I think has been our big contribution as an organization. The theory, practice, lens framework of framing lives in lots of places in the academy. Someone once called it a fractured paradigm, right? Because there was a little bit in linguistics and a little bit in political science and a little bit in sociology and et cetera. And so just trying to bring that together and be able to apply it in a way that works for social movements has been, kind of the first half of our journey as an organization. And now I think we're trying to figure out once you empirically have developed a frame, how do you mobilize it at scale? How do you make sure enough people tell the right story in the right places to drive the change that you want? But to answer your question about process, we start by getting the science down. So, where we want to reframe, what we call it, what we call today MASH, if we want to reframe this, the idea of liver health. We would start by talking to folks like you, right, and your peers in the field, and saying, like, what are the 5 to 7 ideas that if the public really understood this, the policies, the programs, the practices, right, would all go right, right? And so those are our target ideas. A lot of communications professionals, this is a little broad brush and not quite fair, but they kind of stop there. What do you want to say? Let me make it plainer and simpler. Boom, done, right? Um, but we said, what do you want to say? We then go to the public and do send our anthropologists out to very exotic locations like Baltimore and Boise, where they first question their life choices, but then interview folks. What do what's the difference between a person with a healthy liver and one that isn't? Well, why is that? Just are there differences between groups? Well, why do you think so? Right? How would we fix it? What should we do as a society? So we ask a lot of questions like that. We then try to map the gaps between what the field wants to say or what the science says and how the public is thinking. And then we just very systematically, quantitatively, and qualitatively test our way to a set of framing strategies that we can see empirically move people toward the attitudes, the knowledge, and the policy preferences that that set of experts wants to move. And then that's where I usually come into the process. Then the fun part starts, right? We ensure, fun for me at least, we ensure that the people with the power to change the discourse on that issue um, are engaged in reframing the issue and using the best evidence available to shape the talks they give to non-scientific audiences, the blogs and commentaries they write, their social media posts, their conversations in everyday life, right? So we want to make sure that those frames are being used by people who are speaking up on the issue.
Um, that's very interesting. Um, Participants can raise their hand if they have a question. You can also type your question in the webinar chat. We don't have to wait till the end. So we do have a raised hand from Mary Jo. I'm going to see if I can allow to talk. Okay, Mary Jo, you can ask your question, and you can unmute and then ask.
Mary Jo, tell us everything. Maybe it was an accidentally raised hand.
Oh. I got to figure this out on the issue um, um, on the participant list and the chat. Tiff, if you can help with that as well, please. So if we go out on the street tomorrow, anywhere in the world, and we ask people if they know about diabetes or high blood pressure, chances are everyone's heard of it or knows someone with it. And similarly with diabetes. But if we talk about steatotic liver disease, or even its former name, fatty liver disease, no one knows about this. And yet it is a highly prevalent disease. It is silent, like we talked about. And it is, as I described, in the shadow of all these other comorbidities. So, how do we even start to promote this or raise awareness to this issue in such a busy landscape?
Oh, good question. Um, do not start with the steatotic liver disease, whatever.
Yeah, yeah,
Don't start there. That's like S. Birch. No one's going to know what that means, right? I
right.
would start with the bigger value, the collective value that applies to this issue. For the best available advice on this, you would need to actually test this, right? But on the good, better, best continuum, better, right? The better advice I can offer is start with the collective value that's very universalizing. So maybe something like we really want to ensure that when people are not in good health, we're looking and making sure we're finding all the problems, not just the ones that get our attention right away, right? Because often that gives us new insights and new paths, right, to support that patient. And so two things there is like that's an expression of a value of ingenuity or innovation, right? That you're kind of trying to take a fresh or different look at a known and complicated situation. So I might try something like that before you even mention this condition. Because the other thing we would know, the people on the street, the second you say liver disease, people think alcohol abuse, right? I have not done this study, but somebody probably has, and if I did it, I would bet good money that would be the number one thing that comes back. And so our instinct might be to say, and I'm not talking about people with alcohol abuse, right? Because you're trying to make your population seem worthy of attention, deserving, blame-free, sympathetic in a way. And that may be the case, but any worthiness argument is implicitly an unworthiness argument. If you're saying this group of people is, no, we're the good ones, you're really just adding to the stigma, blame, and prejudice against the quote unquote people who did partake heavily in alcohol. So I wouldn't do that, right? I would talk about how the liver is. I don't know anything about livers, Dr. Mystery. I'm sorry, but I would say something about how the liver is a uniquely sensitive an organ or something that is about the biology, right, of the liver, and how what an effect it has on all of the metabolic issues, if that's true, right? But I would say something explanatory about how does it work absent the problem. And then you build in the problem. So when the liver takes on, right, kind of extra fat, then we start to see these cascading problems. But the idea there, the framing that I just did there is start with a value, a collective value, ex offer an explanation, a process, a positive process. What should it look like? What does this thing do? And then introduce the complication. What you've done is you've given people a reason to care, even if they don't understand that they have a direct stake in the issue. You've invited people to think, which then gets them into part of the brain that is the let me learn, not let me pull up quickly what I think I already know about this issue, which is that's the alcohol problem. Right? So you've actually shifted people's cognition into a different space, and then you introduce your problem. So, principle, process, problem, and then you want to offer a proposal. You want to tell people we've got a solution for this, and not, it doesn't have to be a magic bullet solution, but you need to mention there are things we can do. Because otherwise, there's a lot of social problems. As you said, it's a busy, noisy environment. And uh, just amping up people's sense that this is a crisis. As it turns out, that is not the way to break through on most social issues, because everything seems like it's a crisis. Saying there's a problem that we all have a stake in and we can steer our way around it, that is much more engaging.
Wow, that is profound. I remember there was this when I worked in advocacy, one of the toughest challenges was when you had to tell people about something that they didn't know that they didn't know.
Yeah. Yeah. Yeah.
Right? And you had to find a way of engaging with them when they didn't have any knowledge on an issue. And I like that approach of centering it on value, because we all can connect and find commonality with value, even if we don't know something.
Yes, yeah. You've invited people, you've reminded them that they're part of a bigger project, right? You've reminded those collective and universal values, that we're part of a bigger project, and then often they're more curious about how they can help, how they can participate, how they can support, or at least how can they stop spreading misinformation about it, right? So,
That's great. Mary Jo, I see we have you on screen. Would you like to unmute and then you can ask your question? Oh, I think we're still having trouble unmuting. Um, Okay, well, let's see if we can figure that out.
mhm.
So, I want to now go deep dive into a few scenarios that we've come across that,
Okay.
and we're putting you on the spot here, and I know it's a much longer process, but in an hour, if there's just pointers that you might give us. One of the challenges we have is that we live in a time where medical innovation is just progressing every day.
Yeah.
And there's almost this quest for that magic bullet or that silver bullet cure to things. And one of the things we advocate for is a comprehensive approach. So it's not just medication, but it's the lifestyle, the diet, etc. So how do we
Yeah.
frame to reconcile those two or those broad categories of medical versus lifestyle?
Yeah. So trying to stack up the statistics on the side of the argument you want to win, is not the way to do it. It doesn't mean I encourage, hope, and trust that you are an evidence-based organization, right? I'm not saying the data doesn't matter, but often it is your policy analysis or your programmatic analysis, and probably shouldn't be your communications analysis, right? All the things you know we kind of sometimes think that the way humans make decisions is if I just give them all the facts, if they only knew what I knew, they would have the conclusion I have, right? Um, in a busy, noisy time, right? No. For people you're just trying to get to come on the journey with you, that is not a great public facing strategy. I would start with if the communications problem you're trying to solve is I need people to see a wider range of solutions, right? And that it's complex and interconnected set of solutions, not just one thing. That's a great job for metaphor. So I'll tell you two metaphors. I will say if you try them for your issue, you're using them off label. They were developed and tested for another issue. So watch for side effects if you use them. But the two that came to mind instantly is when we were looking at the issue of oral health. People think, okay, oral health, simple, brush and floss, right? And that lifestyle, that personal care is an important part of the issue, but it is also water fluoridation, access to timely, affordable oral health, regular oral health care in a language you can understand and that you can afford. And preventative care in lots of other areas, right? So there's like 17 things that need to happen, not just the one. The metaphor that we worked there was to talking about how to get to good oral health. There's a series of doors. There's like several different doors you have to get through to get to that destination. And people can go through the first door themselves, but if you don't have the keys to the other doors, it does not matter, right? It does not matter that you went through the first door. It does not matter how hard you push on the doors, that those doors are locked, right? And so that was is a metaphor for a series of barriers, right, to the desired outcome in which people thought the only barrier was personal responsibility. And that had dramatic effects. For those advocates on the policy wins that came from that, super helpful. I mean, super effective. The other metaphor that came to mind was the problem we were solving is that people think in education, teachers are the system. Like good, what makes kids, why do kids learn? Well, they had a good teacher. What makes a good teacher? How much they care. End of story, right? And teachers should be high quality and I want teachers to care, right? But there's also the funding of the resources available to that district, the other social conditions, the assessment set of it. There's 17 other things. And that one we talked about how education was like an orchestra or a marching band if you don't have orchestras in your neighborhood, right? And so that each section contributes to the whole, and they need to be coordinated and supported and have time to rehearse and the places to do things, right? And that it was a self-correcting metaphor. Even if people said, but the teacher section has to be really good. Yes, absolutely, but it's not an orchestra if you don't have those extra sections, right? And so meta when to overcome assumed simplicity or false binaries, we have often found metaphor as the way to shift that gear in the brain.
Ooh, that would be a lovely exercise for us to do in our community. Pull together a small group and talk
Yeah.
about that metaphor. And I what I really liked about it, and the key in metaphor is wonderful, that sequential door opening, but also and also the orchestra, which isn't necessarily playing one instrument at a time, but playing it together,
Yeah.
right? For
Yes.
the symphony. And 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 when you show people that it's multifactorial causation,
Yeah.
that sort of takes away the attention of the self responsibility,
Mhm.
because that can be paralyzing. Self stigma is one of
Yeah.
the things to overcome, right?
Yeah. Yes, absolutely. It can be very it helps people who are having a personal experience both hold their own agency and hold the complexity of all the factors, right, that are contributing that are outside of their control. So yeah, I hadn't thought about it as much from the patient perspective, but we have enough evidence testing those sorts of things with people with lived experience that yeah, I think that's a great I can affirm that instinct with evidence.
Um, Absolutely. And yeah, there's often blame attributed to the person who's fat
Yes.
or uses a lot of alcohol.
Yeah.
Um, so, have there been strategies in framing, particularly to tackle stigma? Because there's so much behind stigma, perceptions, people's feelings, attitude, from others, but also to themselves.
Yes, I think we do not often study internalized stigma. That's just not the research we do. So I don't have a lot to say there. In terms of tackling issues where part of the barrier is societal attitudes toward the people with the problem, right? I think that's pretty much part of the work we do. Almost every issue we do has some element of that. The we think about on almost every project we encounter a deep cultural assumption of individualism, particularly when we do that work in America, but not only when we do that work in the U.S. The sense that the causes and consequences of a social problem really come down to personal behavior. Our antidote, I guess, if you will, the counterbalancing mental model that people also have, but just doesn't get enough practice, it doesn't get enough repetition in society. The counterbalancing mental model to individualism is contextualism. What surrounds us shapes us. And so we try to help people find ways to tell that story on their issue. Otherism, the sense that there are distinct groups in society and that whoever we are not the people with the problem. They are the people with and causing the problem for themselves. It's a us versus them type of model. That comes up lots and lots from housing to education to excess alcohol use, tobacco, I'm struggling to think of the 79 issues we've studied, like one that it didn't come up on. And so there, the framing counterbalance to otherism is, I call it togetherism. Our CEO tells me I'm not allowed to call it that, but I don't think he's going to see this webinar. It's much more about a sense of solidarity and shared fates, right? Tell a story of shared fates and collective common cause. So those are, I think, the two that really come to mind in terms of reducing stigma. Also, helping people see policy solutions. Um, because the third kind of big mental model that we come up again and again is fatalism. The sense that it is what it is, there's nothing we can do, the problem is too big to fix. When the counterbalance to fatalism is we designed this, and so we can redesign it, right? It's that systems kind of thinking. It's a yes, we can efficacy kind of thinking. And we have found time and time again that the second you help people focus on policy solutions, big, and it doesn't have to be legislation, but big structural, society-wide, community population level things that we can do, that necessarily takes people's attention to the system, which reduces people's attention to the individual, which reduces blame and stigma. So it's kind of a let me go here to get here, right? Framing move. But if you can keep in mind, you're always up against individualism, otherism, and fatalism. And I need to do contextualism, togetherism, and efficacy, right? You've often, that is so much more powerful than saying, no, 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 don't blame them, don't stigmatize them, which often just reminds people that there's a stigma to begin with. Never remind people of something you wish they'd forget. That's my motto.
And that might be an interesting three-step or three-question
Mm,
preamble for anyone trying to frame things for impact, right?
I think
Um,
so. Yeah. Yeah.
I think that's a very useful tool to go through. But so, and as you're talking and having or raising my awareness to the level of awareness we have to have at a societal context, what individuals go through, the context in which they live, their solitary journeys versus their shared fates,
Yeah.
the way we message that throws them into further denial. I mean, when we worked in HIV, we were like, hey, if you don't use a condom, you're going to die. It was literally that sort of
Yeah.
messaging that was put out. But in order to get to that point, is there work that the individual needs to do in order to sort of raise their awareness, their empathy, their compassion? And Jen's on the call, who heads up Sober Livers, and
Ah.
she says lead with empathy and compassion very often. So is
Yeah.
that sort of work that and what's interesting about the calls we have with the patient community is it's not just patients. With patient advocates, we also have doctors and care providers and family and caregivers as well. So, is there an internal journey that one has to go through to be a better framer?
Oh, that's a fascinating question. Um, I I can answer that from the perspective of how my thinking on social issues and advocacy has changed by working here. Part of what I think is I've changed is I pay attention to a lot of social issues. I'm very much, if you're not outraged, you're not paying attention, right? Type of type of person, right? There's a lot of social change needed in our world. I think one thing that the research that we do has shifted in me is that I understand better that I'm not up against bad people. I'm up against flawed, dominant mental models, right? There are shared ways of thinking that are constantly reinforced, durable ideas that we all absorb. Um, and the person who disagrees with me or says the thing that's uninformed is not a bad person. They are working from the dominant mental model, right? They're breathing the air they're exhaling the air we all inhale. And secondly, that where people start is not where they have to stay, and that those shifts in thinking can actually happen pretty rapidly under the right circumstances. And that those circumstances, there's a part of that I can control. I can control the way I present the ideas. I can control the way I assess the person, right, or the audience, right, that is the people who I disagree with most. Um, and then I think the process that we use of get the science or the field or the expert story down and then get the public story down, like we as advocates should be pretty knowledgeable, right? We really should make sure we've got the expert down. We can't all be what are you, a hepatologist or or is that the people that study snakes? I always get them mixed up. Herpetologist. Anyway, so we can't
Hepatologist is
all.
liver.
Okay, good. Phew.
Yeah, yeah.
We can't all be that, but we can read the Fatty Liver Foundation materials, right? We can do that, and be as informed as we can so that we know the ideas that we're trying to get across. I think those are a couple of things, and then also just ensuring that our hmm, um my ex-husband used to have this saying, do you want to be right or do you want to be married? And my answer was I wanted to be both, and I'm now divorced. But the reason that this is relevant to advocacy is thinking about in your communications, do you want to win the argument or do you want to build a relationship that brings people into this movement? And so that affects your tone and how you show up, and realizing at the first conversation that you might not get the point across then. It may take a series of conversations. You want that to be a longer relationship than winning the argument.
Very interesting. And one of the things we have on a portal that we've created called the Wellness League is we have patient journeys. And we
Uh-huh.
call it journeys specifically.
Yeah.
Obviously, it's an experience over time, but it's not static. It's very dynamic. We learn from it and we learn with others along the way. And one of the things we found is that authenticity with patients showing up to relate their journey, what's worked, what hasn't, pitfalls along the way, eureka is along the way, has been inspiring for other patients. And we found that that connection is, and we still have to get the full data, but anecdotally, it's having a huge influence on behavior change, promoting health-seeking behavior, getting the message across to other patients in that sort of way.
Yeah, and I think that that's a wonderful part of a framing choice that we can make. I started off by saying framing is a set of choices. Who's the messenger? Who's showing up to have the conversation? Ensuring that voice of personal experience is in the room at every table, and that the tables are set so that it's fair and inviting to people who are neither herpetologists nor hepatologists, but just people with people who have experienced this problem. I think that that's super super important. So I'm glad you all are doing that work and bringing that voice to the table.
So we are one of a few patient advocacy organizations, and I think this has been informative for us as the Fatty Liver Foundation and Sober Livers, um, as well as some of our partners who attend this. But let's say next week on Monday at our staff meeting, we say, wow, this can be a really good practice or approach that we take using framing to have greater impact. As a small organization who obviously can't
Yeah.
afford, specialist consultants in this field, what is it that we can do step by step to ensure that we can have this sort of impact in framing?
Yeah. Well, first of all, we live to our nonprofit mission by making the research that big pocket donors, right, fund. All of our money comes from nonprofit sources, and we live to our nonprofit mission by making things freely available to other mission-driven organizations. So one thing you can do is check out the stuff on our website or our social media channels, or come to the webinars that we have. We've got stuff, if were you so inclined, you could stream 48 hours of webinars from me, on YouTube. So there's a lot of self-learning, right? A lot of resources that we make available that I think could be specific. I just put some general resources in the chat. We've got a paper on two that might be, I think, particularly illuminating for you as an issue. And I do understand that this issue is not only and solely, or maybe even primarily, an issue related to alcohol, excessive alcohol use, but it is going to be so in the public's mind. And so we've got a couple resources on fetal alcohol spectrum disorder, and one on framing excessive alcohol use as a policy issue, that I think the insights in there could be of particular use to your organization. Ah, good, you found it already.
Yeah.
And so, start with that, and then, think through. I mean, I think there's the set of questions that I talked about. Those are probably on our website. What is it that you want to get across? What are the conceptual, attitudinal knowledge barriers in your audiences, right, that make that hard to say? Let's try some things, right? Let's frame as strategically as we can with known and available evidence. And let's watch and listen what worked, what didn't, right? If you put yourself through that plan, study, do, reflect, right, cycle, I think on this, would be nice to have the big custom research at on your topic specifically, but I think any organization could be way more effective just doing that self study.
That's very helpful and practical things that we can do at our organizational level. I want to turn to our attendees. If you have
Please,
any
yes.
questions,
I love
please
talking to
raise your
you, but
hand.
Q&A is always my favorite part. So, oh.
Um, any question is a good question. So don't feel shy to ask. You
Yeah,
don't have to be a specialist in this field.
yeah. And comments and reactions too, right? Like not it doesn't have to be a question. Jen
Oh,
Jones, yeah.
yeah.
Hi, this
Good.
is Jen Jones. Can you hear me?
Yeah.
Perfect.
Okay, good, good. Oh, I'm glad you got that fixed because I didn't want to type this whole thing in. First of all, Julie, thank you so much for everything that you shared. Especially, I really liked when you were talking about how you don't want to other the people with alcohol by saying, "Oh, we're not one of those people."
Yeah.
That's been especially hard with, I think, especially, and this is why what the name change is important because we're not saying non-alcohol
Yeah.
anymore. We're not saying what it not is or what it isn't. We're saying what it is with MASLD. So I do really appreciate that. My question to you is where we're running into trouble on the alcohol side is, we have changed the language, which used to be called alcoholic, and we are now saying it's a person with alcohol use disorder, and many other changes in our verbiage and nomenclature when it comes to alcohol. But many people in recovery have recovered through AA and other
Yeah.
programs where they have really gotten the word alcoholic embedded in their system. And in addition to that, many doctors are still using the terminology alcoholic liver disease. I want to respect people who have recovered through
Yeah.
AA because it is an amazing program. And I want people to be able to, label themselves however they want, right? That's their prerogative. But how do we do this in a compassionate way that isn't telling them that they're wrong, but it instead introduces a new terminology if they would like to use it, but also try to encourage this new usage of alcohol use disorder and alcohol associated liver disease as we move forward and trying to really retire the word alcoholic because as you may have seen in studies, it's not really a beneficial label for people in recovery.
Yeah, so I mean, I think, yeah, it's a dilemma and a challenge. We've talked a lot about it, frameworks. We have not studied it particularly, but it's certainly a dilemma that we've spent some time, water cooler conversations around. And in some partnerships, it's been important that we have ways to kind of to navigate that. People's the narrative and peer-to-peer support recovery approach really does encourage, right, that label, and it's part of the process of self accountability and acknowledgement and self understanding, right? So yeah, you definitely don't want to say that word's out of style, right? That's just going to it's disrespectful. And you can't be an effective advocate if you are actively disrespecting the people you're hoping to bring into your movement. I think something you could try is say, I know many of us in this room, have or love someone who describes themselves as an alcoholic or an addict, and we want to support everyone's um, self-definition and recovery. We also know, and I think the people who call themselves, who identify that way also know that we live in a world that thinks that those terms mean moral failure. And so we want to focus people's attention on, on something else. We want to focus people's attention differently. And that's why we, in our public communication, use these terms, right? I would explain it. I would explain it. And I would say that differently on a website, slightly differently than I would say that in a room. The way I would say it in a room is pretty much like what I just said. But I would say your use of the term for your personal recovery journey, I'm there with you. And we're going to use this word because we think it supports the broader movement more effectively. There
Okay.
is not
Yeah.
one magic word that's going to fix it, right? It's going
Yeah.
to have to
Yeah.
be an explanation.
Right. Right. Okay, Julie. Thank you so much. Yeah, we are working on revamping our website, and that is one thing that I have a whole section on is the nomenclature. So maybe I'll see if you could help us out a little bit with that and review it or something at some point.
Yeah, and
But
and check out the excessive alcohol consumption. I'm pretty sure this one has in the last section like a words to watch
oh, good.
um chart that may be helpful for your it does that may be helpful for your
Yeah, it does.
yeah.
Okay, great. Thank you so much. I really
You're
appreciate
welcome.
all that you're doing here. This is such a great conversation. I'm a social science nerd. I love it. I've studied health communication for a while now, so thank you.
Great. Thank you for the great question and for putting this in the time for this in your day.
Um,
Absolutely.
Wow, Julie, that was framing in action. And I'm glad that this is being recorded because I think that was so helpful in showing practically how framing can
Mhm.
just change things around. There was no judgment, there was no taking sides, there was an openness, there was a connection on both sides of the issue. So I think those were all really, really important pointers. I want to see if there's anyone else with a question. We may have time for one more question. Um, no. So, Julie, we have a couple of minutes, and I want to ask you for your one parting message to our community as they embark on a framing approach to have greater impact in the advocacy, patient engagement work that we do.
Ah, Neeraj, no fair. You did not put that on the list. That's that hard, put me on the spot question. The one thing I want to say,
Oh, two or three.
I'm teasing,
Yeah.
I'm teasing, I'm teasing. I mean, I think it would be you're always framing, so always frame strategically. Remember that the work you are doing is so important. You would never pick a medical intervention, a policy position, a programmatic approach because you feel like it. You would be looking really hard and thinking carefully about the evidence that supports that action. We should be at the same place in terms of our communications on the issues we care about. It's not the exact same research you do to find a frame that you do to find the game-changing clinical drug, but kinda, right? You need to go through multiple steps. You need to have a multidisciplinary approach. And you need to realize you can't just make it up. You need to think it through and look to the best available evidence. Our words can change the world, and therefore we should choose the words that change it the most.
Wow. Our words can change the world. I think that sums it up beautifully. Julie, I want to thank you for your time. I want to thank Madrigal, our sponsor. I want to thank the participants for joining this webinar. And we're looking forward to the next one. And I think to conclude, keep framing. Hey,
Frame on. That's what we always say. All right.
frame on. I like that.
Okay.
Thank you so much, Julie.
Thank you. See you soon. Thank you. Good luck, everyone. Bye now.
Yes. Bye.